He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Hey, welcome, folks. It's the Stay Off My Operating Table podcast with Dr. Philip Ovadia. And we are joined today by Dr. Arasi Maran, who I knew absolutely nothing about up until about a half an hour ago when I frantically began my research. I thought the podcast was later, and my phone said, "Hey, you got something coming up." So, Phil, I'm gonna turn it over to you here. You two have more in common than just simply being physicians, and I'm interested to hear what people who are in very closely related but not identical practices of medicine are going to talk about. I'll leave it at that.
Yeah, I've really been looking forward to this conversation. It's always exciting to me when I find another doctor out there in the wild who has come to a lot of the same conclusions, and even more excited when it's someone in the cardiac space. And Dr. Maran and I overlap a lot, right?
Absolutely.
She is an interventional cardiologist, and cardiac surgeons, interventional cardiologists work very closely together. Sometimes there's a little bit of a adversarial aspect of that relationship that we'll talk about, but it was great when she reached out to me and said, "Hey, we've come to the same conclusions. Let's talk about it." I'm going to let Dr. Maran introduce herself, give her background. And we always like hearing about the origin story, because I know that what you talk about now is not what you learned in med school. We went through med school, I think, about the same time. So talk about how you did get here.
Absolutely. First of all, thank you so much. It's really interesting and it's eye-opening to see surgeons also take on this initiative that our work is just not in the cath lab, or it's not just in the OR. It starts way before that. As for myself, Arasi Maran, I'm an interventional cardiologist. I practice at Charleston, South Carolina, but I did my medical school back in India. And I moved to the States maybe 23 years ago, and I've been in Charleston since then. My training, everything was completed here. And I'm an interventional cardiologist. I put stents in people so that they don't have to come to you. But I also specialize in chronic total occlusions, that is blockages, which is blood vessels, which has been blocked for months at a time and completely blocked at that. So see the most severe coronary artery disease spectrum. And as I spent hours working on these heavily calcified, heavily inflamed blood vessels, it kind of, what am I doing? This is too late in the game. I'm interacting with these patients way too late. And it's ridiculous to tell an 80-year-old, eat better, start exercising, change the way you live, manage your stress. I feel like I've missed the boat, and I need to catch people earlier on and preach the preach, or do the talk of, you have to catch yourself earlier on, and you have to fight to stay healthy and prevent such hostile disease from happening. I think that's what, the harder cases I did, the more I started believing the work lies outside the cath lab, outside the clinic. And here I am.
Yeah, I mean, I think you and I share a perspective on that, right? We see patients at the end stage of this disease. And unfortunately, sometimes it's too late, right? Neither you or I can help them. And we try maybe some heroic things that oftentimes, not often, but, occasionally don't end well. But I think you and I both came to that realization, it shouldn't get to this point. Why can't we do something about that sooner? And I'd love to hear your kind of thoughts, right? Why have we gotten to this point where the kind of mainstream medical system really doesn't start paying attention to this disease until it gets to that point? For the most part, patients with heart disease, they really don't get A lot of them don't even know they have heart disease until they get symptoms, which is usually what prompts them coming to see you or I. But why do you think it is like that? Why don't we pay attention to this earlier? Why don't we discover it earlier? Why don't we do better screening like we have for so many other diseases?
I think the system is multifactorial. Number one, I think as human beings, we have taken our health for granted. When we get a new car, we spend at least 10 minutes or 15 minutes of time trying to understand the mechanics of our new car, but never in our lives we are ever taught about this is normal with your health, this is not normal, seek help if this has changed. None of that advice is ever taught. In high school, do they ever talk about seeing a doctor or seeing your primary health care? No, the health education is all about be careful, don't get someone pregnant or watch out for sexually transmitted infections and things like that. But it's never about what you should do to take personal responsibility for your health. That's number one. Number two, I truly believe industrialization of agriculture, when food became abundant and corn became like our basic staple food almost in everything, it just corrupted our natural food chain process, and processed and ultra processed food just crept into everything. Greed, marketing, corporates got into everything and created this perfect ecosystem where we are some of us are obesogenic, some of us are insulin resistant, and we pour this poisonous food into our system. And the healthcare system was just not created, or they never even thought that far. They didn't think we would get this bad this quickly. But the food we eat, food is thy medicine, and the food was so bad, and here we are.
Yeah, you maybe got a little bit of a different perspective at the beginning, right? You went through medical school in India, and then you came here and did your training. I'm sure what most of your colleagues who went to medical school here in the US don't learn about nutrition and its relationship to health in school. Was your experience with that any different in India? I mean, is nutrition talked about in school there, or?
Oh no, I would say it's even worse. It's more about memorizing facts and formulas and protocols and algorithms than it is here. At least here, culturally, I at least saw physical exercise being in the mainstream of the people. But whereas in India, physical activity or exercise is not even in the minds of young adults. It's changing now, but 25 years ago, it was not like that at all. And nutrition was never, I think we had bits and pieces of it in biochemistry in second year of medical school, and that's about it. But we talk about change your lifestyle, change your diet, change your lifestyle, change your diet, without ever defining what that lifestyle should be or what that diet should be, which is very unfair to the patients. If educated people, doctors, don't know what life and diet and lifestyle should be, how can a layperson even know what they are talking about?
When a patient ends up on your table and they're there and they need a stent or a procedure done, invariably one of their most common questions is, why did this happen? How did I get here? I'd love to hear what you tell patients, how you answer that question these days.
I mean, I tell them it's going to be boring. It's not going to be sexy at all. It's going to be very simple, but it's also going to be very hard because you have learned behavior for all these years. And now I'm going to ask you to change those behaviors. That is, here's your spouse. This could be a very long-standing relationship, but I need you to break up another long-standing relationship you have, that is with your food, and that's with or your sodas or with your cigarettes, or you need to break. And most of the time, patients get angry with me as if I'm asking them to cheat on their spouses. That's the visceral reaction they have. And I'm like, then I redirect and see, do you realize this anger you're getting because I'm asking you to change your relationship with the food you eat or the habits you have? And that's where rubber meets the road. If you want to prevent your next heart attack, You need to move more. You need to eat differently. I won't say eat better. I would say eat differently. You have to prioritize your health. You need to fight for your health. And if that fight is not there, there's only so much my stent, the medicines I prescribe, is going to do. It's a partnership. You do your bit and I do my bit, and that's how it goes.
I had a question that I've never asked.
Okay?
And part of it is part of the what's behind this question is my memory of my high school years and my 20s when it was rare to see an obese person. And this was back in 1430 was when that happened. It wasn't quite that. Yeah, I'm an old fart. And listening to you two talk here, and I'm thinking the number one cause of death in the US is heart disease. It's pretty straightforward from everything I've learned over the almost 4 years Phil and I have been doing this show. Most of the time, heart disease is a lifestyle issue. Maybe not all the time, but I would guess a majority of the time. So the question that occurred to me that I've never asked was, what was the number one cause of death in the US prior to it being heart disease, and what year did that happen? So I went to my friend, Dr. Google, and I didn't get the answer I expected. The answer I expected was this was going to happen roughly around the time that Eisenhower had his heart attack and what's his name falsified his Seven Nations study data and convinced us all that we had to start eating low fat. That's not when it happened. It was the late 19 teens.
Yep.
Hmm.
Yeah, it's been
What
over
the heck?
100.
What I'm not understanding. I thought it was, you understand my confusion.
Yeah, yeah. Most people don't realize that it has now been well over
100 years.
heart disease has been the leading cause of death in the United States. And you're right, it came, I think, more to public attention when President Eisenhower had a heart attack in office. But it turns out, and I forget the president, but sometime in the 1940s, I want to say it may have been FDR. Maybe I'm forgetting.
40s, it was either FDR or Truman, so that's easy.
Yeah,
Yeah.
and I can't remember if it was FDR or Truman who actually declared war on heart disease. That was our first public health,
War
right?
on
We've had the
something.
war on drugs, we've had the war on cancer, but
And
the war on heart
we
disease
haven't
was
won one since.
no, we're still over whatever. And but it's it's a great question, right? Why, after 100+ years, have we failed? And I'd love to hear Dr. Maran's take on this, right? My take is that it's because we were fighting the wrong battle, right? We were Don Quixote going after the windmills of cholesterol, and we missed insulin resistance and
Absolutely.
metabolic disease as the root cause of this disease.
I agree with you, but I also think there was another factor which added to heart disease being the number one killer. It was smoking. Do you remember the times when tobacco, nicotine, and cigarettes were considered fashionable and women would lose weight if
4
you
out of 5
smoke,
doctors
etc.?
recommend Lucky Strike. Yeah.
Yeah, so that was causing a lot of heart disease. So that was one phase. Then the attack of on the fats and saying low fat is the way to go, and we completely missed the boat. Encouraged these processed, ultra processed, carb-rich, high sugar, highly palatable foods, and created this multi-generation of metabolic dysfunctional human beings who the grandfather was obese, the father is obese, the grandchild is obese, and it becomes like the whole family, and they come to see the patient and everyone looks about the same, and you can pretty much say everyone is taking or should be taking the same medications or have had the same procedures, and we fooled ourselves. I mean, the breakfast is the healthiest meal, pushing cereals, highly sugary cereals to our children. making them colorful and hyper palatable, we destroyed ourselves. I mean, and I think human beings would be the only species in the animal kingdom, for the sake of money, would destroy themselves. No other species in the animal kingdom will do that to itself. And here we are.
Yeah, my favorite saying along those lines is that humans are the only species smart enough to create their own food and dumb enough to eat it. Covers it pretty well.
Yes.
Yeah, I think you framed it exactly right, because in actuality, Jack, that early rise, right, coming through the teens in the 1920s and the 30s and the 40s probably was largely attributable to smoking. We started to see sugar and processed food come into the picture around that time. And then when you combine these two things, ultimately, it really became a disaster. Now, it's sort of one of the things that I think worked against us figuring out that cholesterol and saturated fat was the wrong pathway initially was things did start to get a little better, right, in the 70s and the 80s and the 90s, which was falsely attributed to the low-fat movement. But in actuality was due to the anti-smoking campaigns, and reducing smoking during that time is what, if you look at the curve around heart disease, there is actually a noticeable improvement starting around 1980. Unfortunately, around 2000, it then shoots back up, and we're now at a spot today that is worse than it was at its high point in the 70s. It is interesting how those two things overlapped. So I guess let's get into the big controversy, Dr. Maran, Arasi. What did you tell your patients about cholesterol and how it plays a role, or how it factors into all of this?
So I tell them it's piece of the puzzle and it's not the entire picture. I do believe in having low levels of LDL, okay? But I'm saying just because you lower your LDL, but you have super high triglycerides, that doesn't make sense. Little poison, lots of poison, it's still poison. You need a balance of that. And again, cholesterol or your lipid panel is not the only thing that matters. Your blood pressure matters. For me, honestly, blood sugars matter. I emphasize very heavily on glycemic control. I mean, I don't go by 5.9. I want 5.5 hemoglobin A1C or even lower. I'm a big believer, if you want to prevent future heart disease from happening, then you want
this is a real good time, because I hear this every week. Hemoglobin H1C, but we're going to have listeners who pop in and out. Real quickly, I didn't mean to interrupt you, but people are going to be wondering, okay, what is that? Hemoglobin A1C, what is it? Why does it matter? And what's the numbers mean?
So hemoglobin A1C basically gives you a 3-month average of what your blood sugars have been. So when you check your fingerstick blood sugar right now, okay, it's the measurement right here, right now. You could have a blood sugar of 100 right now, go eat a bunch of candy and your blood sugar will raise and come down. So it's a spot in time, right here, right now. Hemoglobin A1C goes with a level of 3 months because your hemoglobin is attached to your red blood cell, and your red blood cell lives for 120 days. It's when the glycation, or when the blood sugar attaches itself to the hemoglobin, and you measure that, it tells you the average of 3-month average of what your blood sugars have been. Okay, you want it between 5.9 and above is pre-diabetic. When it is 7 and above, you are diabetic. The American Diabetic Association calls it good glycemic control if it is between 6 to 7. Okay, but as a cardiologist, as an interventional cardiologist who sees, oh God, like blood disease, coronary artery disease in different forms, I think if you can maintain your hemoglobin A1C less than 5.5, 5 to 5.5, then the chances of your second heart attack, your second stroke, comes down dramatically. Having said that, there are 2 ways to look pretty: be naturally healthy with healthy skin, or put lots of makeup to have a flawless skin. And sometimes people overdo with medications and get this hemoglobin A1C. That's too much makeup. You want to change what you eat so your blood glucose comes naturally down and the inflammation comes down and you don't develop more blockages. What do you think, Philip?
Yeah, no, I mean, definitely so. Inflammation and insulin resistance, as far as I'm concerned, are the two driving factors of this disease. And if you take care of those two, and like you said, you have to take care of them well, right? It's not about taking anti-inflammatory medications. It's not about taking medications that are going to help regulate your blood sugar. It's about getting that natural state where we don't have inflammation, we don't have insulin resistance. And that will, and I know this is always controversial when I say it, but we could probably eliminate 95% of atherosclerotic heart disease if we correct insulin resistance and correct inflammation. And unfortunately, and I'm sure you've had a similar experience to me, patients come to our tables and they have never had either of those things checked, right? They've been getting their blood every year and they get their lipid panels. And yeah, they A1C sort of, A1C is a late indicator. By the time your A1C is up, you've been insulin resistant for decades. And most patients have truly never had their insulin resistance or their inflammation measured. And that, I think, is the root cause of this problem. And that's why we haven't made any real progress in 100 years. And again, this is not new information, right? Dr. Kraft figured out in the 1970s that insulin resistance was present in just about every patient with heart disease, if you check it, if you know how to check for it. And unfortunately, that information just got lost and or ignored, depending on how you want to look at things.
Philip, when patients come to your table, they've at least gone through a series of doctors, right? Sometimes when they are having an acute heart attack, I'm the ER or EMS, and I'm their first point of contact. And they're having a heart attack, or the blood vessel suddenly shuts off, and it's an emergency. And we're trying to open up that blocked blood vessel within 90 minutes. It's like a rush. We take the patient to the cath lab, put a stent in. Then I go tell the patient, you had a heart attack, we've cleared the blockage, but I've put a stent in. And lots of times these 30-year-olds and 40-year-olds and sometimes even 50-year-olds will be like, why did this happen to me? But in timeout, when we were discussing the patient, they'll be like, oh, patient's been a diabetic for several years. Last point of contact with a medical professional was 10 years ago, 15 years ago, not been on any medication. Hemoglobin A1C, which is supposed to be 6 or below, will be 13. At that point, your blood is not flowing like the river. It is sticking like maple syrup all along the way and picking up all the gunk all along its way. And at that time, I'm just putting a fancy band-aid by putting a stent. I'm not doing anything to improve the long-term outcome of the patient. I fixed the problem here and there, I've plugged the leak, or so as to speak.
Here's a dumb person question. When you say the blood flows like maple syrup when the A1C is that high, can you literally see that the blood is thick and gooey like that? Or is it more, you got to check it chemically? Is there anything visually obvious about it?
Not necessary. It's more thrombotic in the sense when we are putting wires and catheters, there's a lot of foreign body and blood is getting in touch with plastic. And if it is thick, when the blood sugars are high, if it is about 500 milligrams per deciliter, it forms clots very easily, which is what happens inside the body. But if the triglycerides are high, you can take the blood and keep it outside, and white gunk, like the actual fat, will separate out, like how we separated out in a broth situation or something like that. Yes, we can see it, and it's not pleasant.
Okay, and then a follow-up question regarding blood clots. I don't have a medical license to risk here, so I don't care about asking about it.
Okay.
Have you seen an unprecedented rise in the occurrence of blood clots amongst a younger portion of the population in, say, oh, the last, let's call it 5 years?
Yes. And it is also because we've all become people with hammers. And when you have a hammer, everything becomes a tool. We've also, in the last 5 to 10 years, developed more tools to aspirate clots out of veins and remove blood clots out of the lungs, etc. We are also doing more for them. I mean, there's more technology available for them. So it's people are seeking treatment. What used to be like, oh, just go home, or they don't. Now people, there's advertising happening about these devices, so patients also come to us a little bit more. So it's a bit of a circular argument there, I would say.
Yeah. Okay.
Let's maybe dive in, right? Because I haven't had a chance to really go through this in detail. I think you're the first interventional cardiologist. We've had a few non-interventional people on the show, but go through what it is you're actually doing, right? When you're placing a stent, what this plaque, what your perspective on the plaque is, and maybe also touch on, I think a lot of people don't realize that not all plaque is the same, not all heart attacks are the same. We talk about them as one thing, but in fact, there are a couple of different pathways that ultimately can get people on your table for a stent. But let's go into this a little bit.
Sure. All right. As an interventional cardiologist, I basically use the blood vessels. Guys, 1 minute, time out. I'm having too much of a glare on me. Is that okay? Do you want me to
You're
shift my
actually good.
position? Okay,
No, you're
fine.
good.
Okay, fine. So the heart, I basically, as an interventional cardiologist, get access to the blood vessel either in your wrist or the blood vessel in your groin. I pass a wire and a catheter into the main blood vessel, the aorta, which ultimately leads to the blood vessels of the heart. I inject contrast. The contrast replaces the blood, and I use X-ray to take pictures, and those pictures tells me what kind of blockages there are. Is it with one vessel or is it with multiple vessels, etc., etc. And some patients, the heart attacks, have an acute plaque rupture where you have a lipid plug with like a fibrous tissue on top. For whatever reason, inflammation, insulin resistance, stress, high blood pressure, that plaque ruptures. And the fat which went to repair a tear in the blood vessel now becomes a source of a problem, and you get like actual clot, and real blood clot which you get in your finger if you cut your hand happens inside the blood vessel, and it shuts down the blood vessel, and the muscle supplied by the blood vessel does not get any of its nutrition, and it starts infarcting or dying. That's an acute heart attack. It's an emergency. Patients have that crushing chest pain, sweating like bullets, etc., etc. Then there's another component of it. The plaque slowly builds up over time, and that plaque can be a soft, fibro, fatty plaque or a heavily calcified plaque. And that calcium directly correlates with inflammation in your body. The more inflamed, or if you have kidney disease and your calcium metabolism is messed up, you get this very intense, very hostile calcified plaque. And that leads to chest pain or difficulty breathing with physical activity. And these patients are, oh, something's not okay. And they either show up in their primary care physician's clinic or to a cardiologist clinic. We take those pictures, and those patients usually end up in Dr. Ovadia's table with multiple, all their blood vessels being blocked, etc. We see both kinds of, and we are, unfortunately, the more we see, we can definitely figure out whether it's a clot which caused a heart attack, or it's narrowing because of chronic inflammation, which caused a heart attack. And we also have tools like ultrasounds, which we do inside these blood vessels, which helps us characterize the kind of plaque the patient has as well.
And so I guess I'll just the easiest way is just to ask this, right? What are your thoughts on coronary calcium scans, CAC scans, as a screening test, right? To try and detect this earlier before it becomes so problematic.
Absolutely. It's a great test, but do it in the young, high risk population. Don't do it in a 70-year-old and an 80-year-old. I mean, I had one patient who was 92 years old, and the first screening test that 90-year-old man had was a coronary artery calcium score. That's like looking at a 90-year-old man and saying, oh, you have wrinkles, therefore you should be old. It doesn't make sense. So you have to use the test wisely. If the patient has high risk factors, or there are other parameters of elevated blood pressure, etc., and you want to risk stratify them, go ahead, get a coronary artery calcium score. But you can't just test them one time, and if they have zero coronary artery calcium score, be like, oh, you're good to go, I don't need to see you for 5 years. It does not work that way. Again, this is yet another piece of this really big jigsaw puzzle, and you have to look at it all ways. Otherwise, you're going to be blindsided.
Yeah, definitely. And we talk a lot about that and screening and then repeating, right? Following progression over time. And it's important for people to understand that the calcium score, the CAC score, isn't the end all and be all, right? It doesn't tell us everything we need to know about the state of your disease. But again, it's a great screening test, right? It at least will start to tell you and hopefully alert people, right? Because oftentimes before they have the diabetes, before they have the high blood pressure, right, they may have calcium starting to accumulate in their arteries. And I think it's a great way for waking people up and alerting them to the problem. And then you can start having those conversations about changing your diet and your lifestyle, which is going to be a lot more effective than the person who's already having the heart attack.
But the thing, it's a great test. I truly, a lot of my patients get the test, but it can be falsely negative in female patients because female patients tend to have a lot of non-calcified plaque. So in female patients, I would prefer a little bit more functional test or a stress echocardiogram or something like that. And in my male patients who are more prone for calcific disease, I would send them for coronary artery calcium score. It's nuanced. It's not a box you can check. You have to think about it and put it all together.
Yeah, and we started talking about earlier, right? The true risk factors of this disease, right? Inflammation, insulin resistance. So how do you talk to your patients? Let's say they've come to you, right? They've gotten their stent, and now you're trying to have that conversation around what factors they need to be looking at. What are the things you like to test for, and how do you start having that conversation with them about how to manage these things?
Once they've had a heart attack, my goal is to prevent the second heart attack, okay?
He's probably, for those who are watching, Dr. Ovadia is still in his scrubs, which means he's still got work to do. And every now and then he gets interrupted.
Okay, that's okay.
I briefly interrupted.
I didn't know whether to stop talking or keep going. That's all. So patients who've had a heart attack who come and see me after their stents and their first follow-up appointment, the first thing we go over is most of the men are alpha type A who've had this heart attack. Their egos are crushed. They are depressed and they're broken somehow, or they feel broken somehow. Talking about that this can happen and it is okay. We can't prevent them from having the second one. It is possible, okay? But they have to make certain changes. Number one, exercise. I am a big believer of cardiac rehab, which is basically a monitored exercise program. And if it's a good run cardiac rehab facility, you meet with a nutritionist, you meet with an exercise physiologist, you meet with a psychologist. It adds so many inputs to their post-cardiac care. Number two, we talk about diet ad nauseum, the things they can eat and things they can't eat. And I like to keep it very simple. I avoid snacking. avoid sugary stuff, and avoid second helpings. It's my basic 3S kind of modules. Lots of vegetables, and lots of protein, lots of healthy fats, avocados, olives, macadamia nuts, all of that. And just your carbs should be like your little sides, just for taste, maybe. And exercise as much as you can. Like nothing is more important than exercising in a patient who's had their heart attack after we've done their initial testing and things like that. And if they are smokers or vaping nicotine in any form or any other recreational drugs, we talk a lot about that because that's going to change. Smoking or nicotine exposure is like a forest fire. And there's no point me coming in and fixing their plumbing in their house when the house is burning down because of nicotine or elevated blood sugars. So that's how I categorize my discussion with them for preventing their second heart attacks.
And how much opportunity I know as an interventional cardiologist, you may not have as much opportunity to help prevent first heart attacks and talk to people, but maybe, your colleagues would be more doing this in the what we call non-interventional cardiology space. But I guess, how do you have the conversations with your colleagues these days about what we should be doing to deal with heart disease earlier and try and prevent the first heart attacks?
You'd be surprised how many primary prevention patients I actually see. It's just because they see interventional cardiologists and think this is a super cardiologist, and therefore they like all those biases, but it's okay. Nevertheless, I do see a lot of primary prevention patients, and it's the same framework. You have to change the way you eat. You have to move more, in the sense, just not adding steps, improve strength training, balance training. You have to manage stress. You have to manage your sleep apnea. If you don't wear your CPAP machine, and then that's another umbrella disease which causes inflammation head to toe. So yes, I might be a cardiologist. I do refer a lot of patients for treatment of their CPAP, sleep apnea as well. So it's multifactorial. And sometimes you're a coach, you are telling them, you're motivating them, and you're keeping them accountable, and you're setting them goals so that when they come back and see you in 3 months or 6 months, they better have achieved A, B, and C, and D, and educating them. Most of the time, they don't know what's wrong or they don't know how to fix it. And that's our job.
And how much do you rely on the lab work then? I'm just curious what tests you typically do, either to verify to yourself what's going on or just to be able to show the patient, this is the stuff you need to work on.
So usually it self-selects itself, right? If they're coming to a interventional cardiologist for primary prevention, they're already worried about their health, okay? So I am a minimalist because there are a lot of things you can get, a lot of information with a test you already know. There are some patients who need extra testing, some patients where we need to do the particle size, and some patients we need to do apolipo B, lipoprotein little a, etc. And then some patients who are extremely, you look at them, you've done everything, they are not comfortable with what they are doing. Then I go for, they don't believe me. They don't believe me when I tell them they are high risk. And their ways have not changed. I'm not able to convince them with my usual level of, you're not going the right direction, and I'm really worried you are going to end up on my table. In those patients, I do cardiac CTAs. Now you can do measurements, non-invasive measurements within the CTAs itself to see if you have a tight blockage or not. I do C-reactive proteins, which is again a measure of your inflammation, homocysteine levels, etc. And then I put it all together and said, these are your risk factors, and this is how much each risk factor is contributing to your potential for a heart attack in the next 10 years. And these are the interventions, and this is how much the interventions can reduce you. If your risk of heart attack in the next 10 years is about 20%. My job is to reduce it to less than 6 to 8%. But these are the interventions, and I cannot do it alone. I can sit here on my high horse and preach to you, but you have to be the one to take the actions. And we have good tests right now which tells you how inflamed the patient can be, and risk models which we can use. So I think if someone wants, and there are tough patients, then you have to reach out to their spouse, their mothers sometimes, their brothers sometimes. So it takes a village to take care of this.
Now, I think a lot of the messaging, again, from the sort of healthcare system is medications take care of this, right? So that patient in front of you, for instance, that has the 20% risk over the next 10 years of having a heart attack, and you could give them a list of medicines to go on. What's your perspective on how much that truly modulates their risk, and how much of this really is and can only be accomplished with the diet and lifestyle?
I mean, again, too much makeup versus healthy skin. That's what we are going for. We are going for healthy skin. And yes, I can bring down your LDL cholesterol to less than 55 with the high intensity statins, etc. But if I'm going to do that at the expense of muscle cramps, and because of muscle cramps, you're not exercising, and because you're not exercising, you're becoming a couch potato and eating terrible food, and your hemoglobin A1C goes up, and it's a vicious cycle again. Yes, with just polypharmacy, I can normalize your numbers, and you could still end up with a heart attack. And that I have followed every guideline, but you will still end up with a heart attack. So it is not a one-stop shop. It's not a cookie cutter mechanism. Statins are great. They help in preventing acute plaque rupture and preventing patients from getting heart attacks, but they also promote healing of the ruptures, which leads to calcification, and they all end up with severe calcific disease in their 60s and 70s, and we are dealing with that. I can put you on a boatload of insulin and get your hemoglobin A1C, but if you're requiring 100 units of insulin to get your hemoglobin A1C to 6 to 7, I am not doing you any favor at all. I might be adding to the inflammatory milieu because the fire is still burning inside, and I'm playing whack-a-mole with my little medication regimen. So it's the whole picture. You can't look at one portion, one piece of it at all.
I've got a question for both of y'all because because the guy whose show I co-host is a heart surgeon, and because we have so many people like that on the show, I research my own questions. One of the things that I wish I could say I was surprised by what I found, I'm not. The average heart patient, once he's got level 1 heart disease, I'm not sure I'm saying it, but once they're in the door, they're dealing with some kind of heart disease. The lifetime revenue that he will generate for some pharmaceutical companies between statins, ACE inhibitors, blood thinners, and there's another category. I can't remember what it was. Four major categories. The lifetime
Beta
revenue per
blockers.
patient, like metformin, yeah. The lifetime revenue per patient is $250,000. My thought there is, here you two are working in the hospital, working in the operating rooms, trying to save people's lives. There's zero question that what you are doing is drastic work to try to pull people back from the edge. And historically, we've thought about the pharmaceutical companies as being in partnership with you guys. But the partnership that those of us who don't work in the industry have always thought about was that it was a partnership focused on saving lives and regaining health. It's starting to look to me like the partnership is, we're going to make sure that you've got a steady supply of people to do this work on. How do you, inside the being the folks who are literally saving the lives, do you talk to one another about what the heck the pharmaceutical companies are doing? Is it clear to you, as it is to me, that the incentives have changed drastically? My suspicion is that Phil is not lacking for people to work on, that you're not lacking for people to work on, that there's not a supply problem here.
But it was not just the pharmaceutical industry. It's also the food corporations. It's also the sugar industry. It's also the corn industry. It's also the hospital system. It's also the insurance companies. We are, as a society, victim of all these big corporations. And I'm happy to say is anywhere, anytime, all over, all the time. We are just victims. We have created absolute food addicts, sugar addicts, and we are just thriving. For example, the cereal industry and the whole PepsiCos and the Mars companies and all those companies with their hyper palatable, hyper poisoned food. Didn't we just see, which came out of Florida, the amount of arsenic in regular candy? So they are feeding the system, and it starts very early. And I don't think you can just blame one industry. You want to blame them all, I would say, Jack. They are all together with this. And he sees the worst of it. I see the worst of it. I'm starting in my lab wearing 20 pounds of lead and working 3 hours trying to clean out the calcium, doing roto-rooters and stuff like that. But the damage was started 40 years ago. So even before I was born in some of these patients.
Yeah.
Yeah, I certainly agree. We can't just blame the pharmaceutical industry. Honestly, I don't really blame the pharmaceutical industry because they're doing what they're supposed to do. I'm very much a capitalist, and the role of corporations is to maximize the value for their shareholders. And so pharmaceutical companies say, we got all these sick people, let's find drugs that might help them. Now, I do blame them because I think they are dishonest, right, about the effects that their medications have, both overemphasizing the positive effects and minimizing the negative effects. I think that the way that they've ingrained themselves in the medical education system is problematic. And I think there are lots of problematic aspects of how they go about their business. But ultimately, you're right, they're just fulfilling demand. And I'm not sure that they created that demand. I look at the food industry and I look at our government, quite frankly, that created this demand in the first place. And but I do think that more and more physicians, Dr. Maran and myself, are waking up to this, right? Yeah. We are literally overwhelmed. The supply problem in medicine is not actually with the patients, it's with the doctors. There are not enough heart surgeons, there are not enough interventional cardiologists to go around and take care of all these sick people. And it's not a problem of, oh, we just need to train more surgeons or more cardiologists. It's we need less sick people. And thankfully, I think that the healthcare system is starting to wake up to this. So I'm going to turn this to an optimistic thing. And I'm going to say, here we are, we're recording this February 9th, the day after the Super Bowl. And at least in my mind, and I didn't actually watch the Super Bowl, but the most impactful commercial that occurred during the Super Bowl was Mike Tyson talking about eating real food. And this is on the newly released food pyramid. So I'd love to hear your perspective on all of that this is now part of the public conversation. This is part of the ethos. And we have people that I think are finally waking up to the food problem that we have.
Absolutely. I'm not dogmatic about one way or this way, right or left or whatever, but I truly believe our food pyramid was messed up, and them adding carbs at the base of the pyramid is ridiculous. I mean, yes, you can have healthy carbs as vegetables and fresh fruits and etc., but that was not how the food pyramid was interpreted. Instead, that carb section was interpreted as let's have bread and pizza and waffles and cookies and cakes. It was completely warped. So flipping it around and and giving a good space for healthy fats, which actually makes you full and therefore makes you eat less, it deserves its rightful place in the food pyramid. It's when we stopped buying chicken and chicken stopped looking like chicken and fish stopped looking like fish and it was replaced by something else, that's when the problem started. And we just have to be keep on going. The fight is not over. And unfortunately for humankind, when we solve this problem, another problem will come up in life. Maybe pollution will become a problem. I don't know. It's already a problem. So it's an ongoing, we have to keep evolving. We have to keep evolving, and we cannot get dogmatic that this is the only way to achieve health and all the other ways are wrong. As I said, it's not a cookie cutter, one size fits all. And each person, each individual has to be, it's a custom fit made for each individual.
Perfect. You're on mute, Jack.
Do we have time to ask one more question?
Sure.
Okay. I know Phil's got to get out of here and go see a patient.
Yes.
This may be an utterly ignorant question. And if it is, I'm totally okay with that. That's my job here. Old story, old news. Dr. Linus Pauling, who won 2 Nobel Prizes, proposed that the root cause of heart disease was, I can't remember what the exact mechanism was, but his proposal was that vitamin C would repair the tears in the arteries that were collecting cholesterol. And I know that has been largely vilified. I have zero horse in this game, but given what I have learned about the dishonesty of the untrustworthiness of a lot of medical accepted wisdom, is that something worth revisiting as it relates to heart disease?
All I would say is there's no one magic pill which will fix all of it. And if there was one such magic pill, the pharma industry would have found a way to market it and sell it to all of us at an exorbitant price. I promise you that would have happened. There is no one magic pill. Again, just to focus on vitamin C versus vitamin B, or it's too narrow. It's a very narrow focus. Life, unfortunately, is not that easy, and coronary artery disease is not that simple.
Yeah, I would agree. I think there is some validity to, Dr. Pauling's work, but it's not just vitamin C, and vitamin C isn't going to cure all of heart disease. And again, vitamin C may be helpful, right, in repairing that damage, but you got to ask, why was the damage there in the first place?
Yeah,
that's really what gets us back to the root cause.
Yeah.
That's my perspective. This has been a great conversation. Why don't you let people know where they can learn a little bit more about you?
Sure. I'm on LinkedIn. I'm on Instagram. I'm at Doc Arasi Maran, and my website, drarasimaran.com. I have a podcast called Reboot with Dr. Arasi Maran, but feel free to message me in LinkedIn, DM me in Insta, whatever. And the goal both of us are trying to do here is you can take care of yourself just by yourself. You don't need Dr. Phillips' help or Arasi's help. The information is out there, and there is no substitute for common sense. If the food does not look like the real thing it's supposed to be, maybe you should think about why it's being sold. I will end there.
I like that. If it doesn't look like real food, maybe you ought to consider whether or not you should be eating it.
Yes.
All right. Our guest has been Dr. Arasi Maran. Sorry about that. This has been Stay Off My Operating Table with Dr. Philip Ovadia. We appreciate y'all taking time out of your day to listen. The contact information for Dr. Maran will be in the show notes, as always. And we'll talk to y'all next time.
Thank you very much.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.